Cardiovascular agent and molecular targets. This is cardiovascular pharmacology. Step 1, first aid. Very high yield, extremely high yield for step 1 through step 3. Cardiovascular agents are dihydropyridine calcium channel blockers. There are a total of 5 drugs in this class. Dihydropyridine calcium channel blockers. There are 5 drugs. They act on L-type voltage gated calcium channels. As you can see, this is blue channel, which looks like a channel, and these calcium channel blockers, they block them. What are the calcium channel blockers? Amlodipine, clevidipine, nicardipine, nifedipine, nimodipine. These are the 5 dihydropyridine calcium channel blockers. What are the GI agonists? GI agonists are epinephrine, norepinephrine, which act on alpha-2 receptors, favorable for alpha-2 receptors, epinephrine, norepinephrine, and they act on GI agonists, which means that eventually GI inhibits adenylate cyclase. Next, GS agonists are epinephrine, which acts on beta-2 receptor, prostaglandins, prostacyclin, phenol dopam D acts on D1 receptors. D1 receptors, phenol dopam. Another way to remember D1 is F1 race. So D1, F1 race, like the car race F1. So phenol dopam is D1 receptor. Adenosine is also GS agonist. S for stimulation. So GS means it positively stimulates adenylate cyclase. What are phosphodiesterase 3 inhibitor? Phosphodiesterase 3 inhibitors are milrinone. Only one drug in this class, phosphodiesterase 3 inhibitor, is milrinone, which inhibits phosphodiesterase 3, eventually stopping CAMP conversion from to AMP conversion. Then next is phosphodiesterase 5 inhibitor. Phosphodiesterase 5 inhibitor is sildenafil. Just to remember that S for sildenafil, S looks like 5. So 5, phosphodiesterase 5 inhibitor. Next is natriuretic peptide agonist. Natriuretic peptide, natriuretic peptide are ANP and BNP. So natriuretic peptide agonist acts on natriuretic peptide receptor of natriuretic peptide ANP and BNP, which eventually positively converts GTP to cGMP via guanylate cyclase. So ANP and BNP are natriuretic peptide agonists, and they act on natriuretic peptide receptors. Now uh, let's see what are the medications that are acetylcholine receptors for acetylcholine agonist. They are alpha-2 agonist, bradykinin, cytokines, histamine, serotonin, shear stress. So what activates a acetylcholine receptors? This is actually very important, guys. So acetylcholine receptor is activated by alpha-2 agonists. We just read that alpha-2 agonist is epinephrine, norepinephrine. So acetylcholine receptors are activated by alpha-2 agonists, bradykinin, cytokines. Cytokines are released in inflammatory process, infection, even some cancer. Cytokines, histamine, like allergic reaction, serotonin, like serotonin is actually a happy hormone, so that positively acts on acetylcholine receptor. And shear stress. So if there is the stress, for example, if somebody has a burn, third-degree burn is a physical stress, so that will also stimulate acetylcholine receptor. So acetylcholine receptor is activated in these 5 conditions. Let's dive into individual drugs. And so Also, nitrates is one of the class of the drug that acts on nitric oxide. L-arginine positively stimulates nitric oxide. And then GQ agonist. GQ agonists are epinephrine, norepinephrine, which are also alpha-1 receptor, alpha-1 receptor. And then endothelin 1 receptor, angiotensin 2 are GQ agonists, vasopressin. Again, so GQ agonists are four class of drugs: epinephrine, norepinephrine, endothelin 1 receptor agonists, and angiotensin 2 vasopressin. Nitrates. What are nitrates? What are nitrates? Nitrates are the class of drug that are used in angina, acute coronary syndrome, and pulmonary edema. So there are three clinical uses of nitrates: angina, acute coronary syndrome, pulmonary edema. What are the drugs in nitrates? Nitroglycerin, isosorbide dinitrate, isosorbide mononitrate. These are the three class of drugs that are under classification for nitrates. Mechanism for nitrates is vasodilation by increasing nitric oxide in vascular smooth muscle, which increases CGMP and smooth muscle relaxation. So nitrates vasodilate by increasing nitric oxide in vascular smooth muscle, leading to increase in CGMP and smooth muscle relaxation, which helps in dilation of veins. It also dilates arteries, but veins dilate 2 times faster with nitrates. So veins dilate, veins are valveless. So veins dilate 2 times faster than arteries. If veins dilate, this is a vein. Now vein is given nitrate, it becomes like this. So obviously pressure goes down. This leads to decrease in preload, decrease in preload. And in what condition do we use nitrates? We use it in angina, acute coronary syndrome, like myocardial infarction, Prinzmetal angina. ACS is a big umbrella term. Pulmonary edema. Pulmonary edema is another condition where you can use nitrates. What are the side effects of nitrates? Reflex tachycardia. Reflex tachycardia can be seen. So because the preload goes down, heart senses as a low hypovolemic condition, and this leads to increasing in heart rate. So this is reflex, which means it is the secondary response. So reflex tachycardia, if you see reflex tachycardia with nitrates, you give them beta blockers. Most favorite beta blocker of all the cardiologists in the world is metoprolol. So metoprolol, you can start with metoprolol 5 mg milligram IV, easy peasy. Methemoglobinemia can be caused by nitrates. Hypotension, flushing, headache, Monday disease. This is Monday disease is the colloquial term. It is for industrial nitrate exposure. What happens is people who are working in industries, they are exposed to nitrates, and because Sunday they are fine, suddenly Monday when they go to work and they are exposed to nitrates, they experience hypotension, flushing, headache. So that is in the Monday disease. And development of tolerance for vasodilating action during work week and loss of tolerance over the weekend. So this leads to tachycardia, dizziness, headache upon exposure. uh, what is contraindicated while you are on nitrates? So if somebody is on nitrates, you cannot give them at any point phosphodiesterase 5 inhibitor. Phosphodiesterase 5 inhibitor also vasodilates. Nitrates also vasodilates. So and also nitrates are contraindicated in right ventricular infarction, right side MI. So right side MI 2-3 AVF. This is the ECG findings of right heart failure. Right heart failure, don't give them nitrates, give them IV fluids. Hypertrophic cardiomyopathy, HOCM patients are dependent on preload. They need more preload. So do not give them nitrates. And with concurrent phosphodiesterase 5 inhibitor, sildenafil, Viagra. Next is calcium channel blocker. What is calcium channel blocker? Calcium channel blockers are amlodipine, clevidipine, nicardipine, nifedipine, nimodipine. These are dihydropyridine and they act on vascular smooth muscle. What are the calcium channel blocker drugs that act directly on the heart? They are diltiazem, verapamil, diltiazem, verapamil, diltiazem, diltiazem, verapamil, verapamil, diltiazem, verapamil. Diltiazem, verapamil directly act on heart and they are called non-dihydropyridine calcium channel blockers. One of the easy way to remember this is that they act on heart, they don't let you die. So non-die doesn't allow you to die. So diltiazem, verapamil, non-dihydropyridine calcium channel blockers act directly on heart. Okay, so mechanism of action for calcium channel blockers in general, calcium channel blockers block voltage dependent L-type calcium channels of cardiac and smooth muscle. So L-type calcium channel in cardiac and smooth muscle are blocked by calcium channel blockers. This leads to decreased muscle contractility, decrease muscle contractility, decrease muscle contractility with the help of calcium channel blockers. Vascular smooth muscle, amlodipine, nifedipine are more effective than diltiazem and verapamil. So amlodipine, nifedipine, these are more effective than diltiazem and verapamil. On heart, verapamil is stronger. Diltiazem is more stronger than amlodipine and nifedipine. So vascular smooth muscle, most strongest medication is amlodipine, nifedipine. Heart, most strongest is verapamil. Clinical use of calcium channel blocker. Except nimodipine, all dihydropyridines are used for hypertension, angina, including vasospastic angina. Vasospastic angina means that they have vasospasm and they experience angina like symptoms, but it is only because there is no permanent damage. So the tissue has not died yet. So there's only a little bit of spasm in the vessel causing decreased blood supply. Otherwise, patient is fine. So the dihydropyridine, except nimodipine, helps in hypertension, angina, including vasospastic type, Raynaud phenomena. Dihydropyridine mainly dilates arteries. So then nimodipine is used in subarachnoid hemorrhage because it prevents delayed ischemia. Subarachnoid hemorrhage. Also, there is a classic question in step two question that patient undergoes open craniectomy for subarachnoid hemorrhage, and then post-operatively patient experiences stroke. What medication was not given to the patient after the open craniectomy? Answer was that nimodipine was not given because nimodipine helps prevent delayed ischemia. So stroke symptoms are never normal. Preoperative, postoperative, at home, outside, in the park, grocery store, wherever the patient is, stroke symptoms are never normal. Patient needs nimodipine. Next condition is nicardipine, clevidipine. They are used in hypertensive urgency or emergency. Urgency, emergency, these are two different conditions. Hypertensive urgency, emergency, use nicardipine, clevidipine. Non-dihydropyridine, non-dihydropyridine like diltiazem and verapamil are used in hypertension, angina, rate control in AFib, atrial fibrillation, flutter, prevention of non-nodal arrhythmias. Atrial fibrillation is very common. Atrial flutter is not very common. Atrial fibrillation needs to be controlled because atrial fibrillation can lead to ventricular fibrillation. Ventricular fibrillation means death. Ventricular fibrillation means death. So you need to prevent this by giving non-dihydropyridine calcium channel blocker like diltiazem, verapamil. Adverse effect of calcium channel blockers are gingival hyperplasia. Gingival hyperplasia is one of the main adverse effects of calcium channel blockers. Non-dihydropyridine calcium channel blocker adverse effect is cardiac depression, AV block, hyperprolactinemia, verapamil, constipation. Adverse effect of calcium channel blockers is gingival hyperplasia. Dihydropyridine causes peripheral edema, flushing, dizziness. Peripheral edema is very common. Adverse effect of dihydropyridine calcium channel blocker, and you can also see flushing, dizziness. Non-dihydropyridine calcium channel blockers adverse effects are cardiac depression, AV block, hyperprolactinemia, verapamil. Hyperprolactinemia is seen with verapamil, and constipation. Although verapamil side effects, you also experience constipation. So hyperprolactinemia and constipation, these both of these are adverse effect of verapamil. Next medication, hydralazine. Hydralazine. Hydralazine is a medication that causes smooth muscle relaxation by increasing CGMP. Hydralazine vasodilates arterioles. Hydralazine vasodilates arterioles, and therefore you see a decreased reduction in afterload. So afterload reduction seen with help of hydralazine because it vasodilates arterioles by increasing CGMP, leading to smooth muscle relaxation. Clinical uses of hydralazine are severe hypertension. In emergency departments where patient presents with severe hypertension, acute presentation, you need to give them hydralazine, IV hydralazine. Usually you start with IV hydralazine 50 milligrams, 50 milligrams. So patient with heart failure with organic nitrate, you give them hydralazine. Hydralazine is safe in pregnancy. So pregnancy hypertension is 140 over 90, more than 140 over 90 in pregnant women. More than 20 weeks is, so if it's before 20 weeks, it's chronic hypertension. After 20 weeks, it's just pregnancy-induced hypertension. Either ways, you give them hydralazine and frequently administered with a beta blocker to prevent reflex tachycardia. So again, if you experience reflex tachycardia, give them beta blocker like metoprolol. Compensatory tachycardia contraindicated in angina. So adverse effect of hydralazine is compensatory tachycardia. Compensatory tachycardia is a big side effect of hydralazine, and therefore hydralazine is not the preferred drug in angina or coronary artery disease. Hydralazine also causes fluid retention, headache, angina, and hydralazine causes drug-induced lupus, drug-induced lupus, drug-induced lupus, drug-induced lupus. What are the drugs that causes lupus? Hydralazine, sulfonamides, isoniazid, and prokinamide. Hypertensive urge emergency. Now, hypertensive emergency is a condition where you see almost always end organ damage. And hypertensive emergency treated with labetalol, clobidipine, phenoldopam, nicardipine, nitroprusside. Again, the drugs used to treat hypertensive emergency, hypertensive emergency, hypertensive emergency. Drug of choice is labetalol, clobidipine, phenoldopam, nicardipine, nitroprusside, labetalol, clevidipine, phenoldopam, nicardipine, nitroprusside. Nitroprusside is a short-acting vasodilator. Short-acting vasodilator. Nitroprusside is a short-acting vasodilator. It acts on arteries and veins. Nitroprusside acts on arteries and veins, and it's a short-acting vasodilator. Nitroprusside increases CGMP via direct release of nitric oxide. Can cause cyanide toxicity. Release cyanide. Release cyanide. Release cyanide. Can cause cyanide toxicity by releasing cyanide. Dopamine D1 receptor agonist. Phenoldopam is dopamine D1 number 1 receptor agonist, and it causes coronary peripheral renal splanchnic vasodilation. So where does phenoldopam act? Phenoldopam acts on dopamine D1 receptor agonist, and it causes coronary peripheral renal and splanchnic vasodilation. So phenoldopam helps in lowering blood pressure, and it increases natriuresis. Natriuresis means you pee out nitrites. So natriuresis. Also, phenoldopam is used post-operatively as a antihypertensive, as it can be given IV via intravenously. So side effect of phenoldopam is it can cause hypertension, tachycardia, flushing, headaches, nausea. Hypotension, tachycardia, flushing, headache, nausea. Phenoldopam side effects are hypotension, tachycardia, flushing, headache, nausea. Now, anti-anginal therapy. The goal of anti-anginal therapy is to reduce myocardial oxygen consumption. So uh, anti-anginal therapy is given to decrease myocardial oxygen demand. To decrease oxygen demand in uh, to decrease oxygen demand in myocardia, you use anti-anginal drugs. So MVO2 is the short form for myocardial oxygen consumption or demand, either ways. So you decrease by one or more of the determinants of MVO2. So the way you decrease oxygen, think of myocardium as this is the myocardium. If the myocardium doesn't have enough blood supply, which is leading it to myocardial infarction, patient experiences angina, sorry. So in those cases, you give anti-anginal therapy. Anti-anginal therapy is given when patient is experiencing chest pain because it is a symptom of angina. So MVO2 is decreased. MVO2 is decreased by anti-anginal therapy by decreasing end diastolic volume, blood pressure, heart rate, contractility. So four things that can help us to decrease myocardial oxygen demand are by decreasing end diastolic volume, EDV, end diastolic volume, blood pressure, you decrease the blood pressure, oxygen demand decreases, heart rate. So heart rate, if the heart is pumping slowly, it will use less oxygen. and the same contractility, heart rate, they are interrelated. So now let's see what are the key differences between nitrates, beta blockers, and then nitrate beta blocker combination. Nitrates with beta blockers in combination. So end diastolic volume is lowered with nitrates. End diastolic volume is lower with nitrates. In beta blockers, end diastolic volume does not have any effect, or end diastolic volume can also increase with beta blockers. However, if you give nitrates and beta blockers together, end diastolic volume can have no effect or it can lower. If you give nitrates to patient with high blood pressure, the blood pressure lowers, blood pressure goes down. Beta blocker, blood pressure also goes down. So net effect with nitrates and beta blocker is that they both lower the blood pressure. They both lower the blood pressure. So nitrates plus beta blockers lower blood pressure. What happens if you give nitrates in tachycardia? So tachycardia means increased contractility. So if you give nitrates, the contractility increases. You remember we read reflex tachycardia. So reflex response increases, causing increased contractility. With beta blockers, contractility decreases. So they both cancel out each other. If you give them together, they both cancel out each other. And now let's see what happens if you have increased heart rate. So contractility and heart rate, they are the same thing. So results are the same if you give nitrates. So if you have increased contractility, increased heart rate, you give nitrates, they tend to increase with reflex responses. In 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 situation where you have increased contractility and increased heart rate and you give a beta blocker, they both will go down. Net effect is that they cancel out each other. Ejection time is lowered with nitrates and increased with beta blocker. Ejection time is lower with nitrates and increased with beta blocker. Net effect of nitrate and beta blocker given together is that they cancel out each other, so little or no effect is seen in ejection time with combination of nitrate and beta blockers. Now, myocardial oxygen demand. This is most important thing, most high yield concept as well. Myocardial oxygen demand decreases with nitrates and decreases with beta blockers. Net effect is that it decreases a lot. So there are downward arrows. Double downward arrows if you give nitrates and beta blocker together to decrease the myocardial oxygen demand. So non-dihydropiridine calcium channel blockers are verapamil diltiazem, and they act in a similar way as beta blockers in effect. Only difference you need to remember specifically is that myocardial oxygen demand decreases in nitrates and beta blocker both, and end diastolic volume decreases with nitrate but has no effect with beta blocker. Heart rate contractility are same, so they both increase with nitrates and decrease with beta blockers. Contractility, heart rate increases with nitrates, decreases with beta blockers. Moving on, next medication is ranolazine. Ranolazine mechanism is it inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension and oxygen consumption. It does not affect heart rate or blood pressure. So ranolazine can be safely given in patients with low blood pressure. Ranolazine inhibits late phase of inward sodium current, thereby reducing diastolic wall tension and and oxygen consumption. So Do you give ranolazine? Ranolazine is given in refractory angina. Refractory, the word refractory means not being able to treat with the first line drug of choice, second line drug of choice, third line drug of choice. Refractory angina. You tried beta blockers, nitrates, everything, and then last resort is ranolazine. Ranolazine. Ranolazine is a uh, comparatively newer drug, and it is very expensive drug. It is very expensive drug, not covered by Medicare, Medicaid. So mostly patients pay out of pocket. Ranolazine. Again, so adverse effect of ranolazine, it causes constipation, dizziness, headache, nausea, and QT prolongation. So QT prolongation is a whole another video and topic to discuss, but just remember in short that ranolazine decreases contractility by inhibiting late phase of inward sodium current, thereby reducing diastolic wall tension, and therefore it increases QT prolongation. Other adverse effect of ranolazine are constipation, dizziness, headache, nausea. Next medication is sacubitril. Sacubitril is a drug of um, choice if patient are experiencing HFrEF, which means heart failure with reduced ejection fraction. Sacubitril is actually now FDA approved, and it is given if CHA2DS2-VASc score is more than 7.5, you automatically start them on sacubitril. Mechanism of action of sacubitril is a neprilysin inhibitor, which prevents degradation of bradykinin, natriuretic peptides, angiotensin II, and substance P, leading to increased vasodilation, decrease ECF volume, decrease extracellular fluid volume, decrease decrease ECF volume, increase vasodilation, decrease ECF volume. Clinical use of sacubitril is it is used along with valsartan, which is a ARB, angiotensin receptor blocker, uh, to treat HFrEF, heart failure with reduced ejection fraction. So HFrEF patients usually present with ejection fraction of 20 to 25% or even 15%. Normal ejection fraction is 55% to 60%. 55% to 60% is normal ejection fraction. Low ejection fraction patient receives sacubitril. Adverse effect of sacubitril is it can cause hypotension, hyperkalemia, because again it is a ARB component of HFrEF therapy that causes hyperkalemia, because ARBs are low intensity diuretic. So sacubitril can cause hypotension, hyperkalemia, cough, dizziness, contraindicated with ACE inhibitor due to angioedema, because both drugs, sacubitril and ACE inhibitor, increase bradykinin. There is a small diagram here that is worth looking into, because it explains how sacubitril inhibits angiotensin II and natriuretic peptides to form inactive products, and therefore, so because sacubitril is inhibiting angiotensin II receptor, angiotensin II gets shunted towards vascular tone and causes aldosterone secretion. So sacubitril inhibits natriuretic peptides, and natriuretic peptide inhibits aldosterone secretion. So angiotensin receptor valsartan inhibits angiotensin II from acting on the aldosterone secretion. So in other words, angiotensin 2 goes up. So sacubitril. This is the effect of sacubitril. Now, main lipid lowering agents. Lipid lowering agents are very, 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 very important because America, as you know, has obesity epidemic, and almost every obese person, obese means BMI of more than 30, they get statin, even pediatric population. So 12 years and above, you can put them on statin if they are obese, if their BMI percentile is more than 90%, put them on statin. So statins, main drugs are atorvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin. Usually in clinics, you get generic uh, prescription of atorvastatin and rosuvastatin. These are high intensity statins. They decrease LDL. They decrease LDL, hugely decrease LDL, and increase HDL. HDL, high density lipoprotein, the good lipid, is increased. However, LDL is decreased a lot. And statins also decrease triglycerides. Mechanism of action of triglycerides is that it inhibits HMG-CoA reductase, decrease cholesterol synthesis, decrease intrahepatic cholesterol, increases LDL receptor recycling, which means you eventually have increased LDL receptors, and increase LDL catabolism. Catabolism means breakdown of LDL. So eventually LDL comes down, level of LDL comes down. So if receptor goes up, the level goes down. So LDL receptors are increased, so LDL level comes down. And what are the side effects? So side effects of statins is hepatotoxicity. It increases LFTs. You can experience myopathy. In clinical vignette, they would say that creatinine kinase CK is increased. This means that patient is experiencing myopathy secondary to uh, medication, or uh, creatine kinase can also increase in excessive exercise. So myopathy is mostly seen when statins are given in combination with fibrates or niacin. Next, lipid lowering agent is bile acid raising, which is cholestyramine, 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 bile acid raising, cholestyramine, cholestyramine, cholestyramine. These medications decrease LDL and slightly increase HDL and triglycerides. Bile acid raisins slightly increase HDL and triglyceride, but they lower LDL. Mechanism of action of bile acid raisins are that they disrupt enterohepatic bile acid circulation. Disrupting enterohepatic bile acid circulation causes compensatory increase in conversion of cholesterol to bile and decrease intrahepatic cholesterol, and increasing LDL receptor recycling. Adverse effect of bile acid raisins are it causes GI upset because it decreases absorption of other drugs and fat soluble vitamins. So, if you have low fat soluble vitamins and low absorption of other drugs, you can experience side effects like, so fat soluble vitamins are A, D, E, K, vitamin A deficiency, D deficiency, vitamin E deficiency, vitamin K deficiency can be experienced if you take bile acid raisins regularly, and you can also experience generalized GI upset like abdominal pain. Next lipid lowering agent is ezetimibe. Ezetimibe. Ezetimibe lowers LDL and increases HDL, but decreases triglyceride also. So mechanism of action of ezetimibe is prevents cholesterol absorption at small intestine brush border. Small intestine brush border level, it prevents cholesterol absorption. So patient on ezetimibe is not able to absorb cholesterol from the food that he eats. An adverse effect of ezetimibe is that it increases LFT. It's a rare side effect, but still there, increases LFT, and it can also cause diarrhea. So again, all these lipid lowering agents like statin, bile acid resins, ezetimibe, and also the drug of choice. So it's in the same order. First is statin, second is bile acids, and then third, if nothing works and patient continues to experience side effects, give them ezetimibe. Next, lipid lowering agent is fibrate. Fibrates have two drugs which are fenofibrate, gemfibrozil. They both decrease LDL, increases HDL, but hugely decreases triglyceride. Hugely decrease triglyceride. However, if in a question you see that the triglycerides are in thousands, if patient has triglyceride in thousands, only then you add fenofibrates. If the triglycerides is in 200, 300, 400, just add statin. Statin is drug of choice number one, lipid lowering. So again, mechanism of action of fibrate is activates PPAR alpha, It upregulates LPL, lipid, protein, lipoprotein, lipid, protein, lipoprotein, increases triglyceride clearance. It clears triglyceride from the system. So activation of PPAR alpha induces HDL synthesis. Because PPAR is activated, HDL is formed. Side effects of fibrates are the same as any other lipid lowering agent. Myopathy increases risk with statins. If you give statins and fibrates together, you have severe myopathy. And then another very specific fibrate side effect is that it can cause cholesterol gallstones via inhibition of cholesterol 7 alpha hydroxylase. Next, lipid lowering agent is niacin. Niacin lowers LDL and increases HDL. Triglycerides is also lowered with the help of niacin. Mechanism of action of niacin is it inhibits lipolysis, which is hormone sensitive lipase. Hormone sensitive lipase is uh, lipolysis. So, mostly niacin acts in adipose tissue. It reduces hepatic VLDL synthesis. In adipose tissue, reduces hepatic VLDL synthesis. Adverse effect of niacin is flushed face, prostaglandin mediated, and to prevent flushed face, you can give NSAIDs or long-term NSAIDs. NSAIDs can prevent from getting flushed face, which is a side effect of niacin. But niacin can also cause hyperglycemia and hyperuricemia. So niacin side effects are flushed face, hyperglycemia, hyperuricemia. For flushed face, you give them NSAIDs like Tylenol, Motrin. Next, PCSK9 inhibitors. PCSK9 inhibitors are evolocumab. PCSK9 inhibitors are very good drugs in the sense that it decreases LDL immensely and increases HDL, decreases triglyceride. But only thing is that every good thing is very expensive. So PCSK9 is not the first drug of choice because of the cost of the drug. And mechanism of action of PCSK9 inhibitors is that inactivation of LDL receptor degradation, increases removal of LDL from bloodstream. Adverse effects are myalgias, delirium, dementia, other neurocognitive effects. PCSK9 inhibitors adverse effects are myalgias, delirium, dementia, and other neurocognitive effects. Uh, Another lipid lowering agent is fish oil and marine omega-3 fatty acids. These are over the counter garbage, fish oil and marine omega-3 fatty acids. You can even find it in Walmart, any local pharmacy. Fish oil, marine omega-3 fatty acids. It slightly increases LDL, increases HDL, and slightly decreases high doses. This is why I call it garbage, because it doesn't do anything. And it is believed to decrease free fatty acid delivery to the liver. There is no proof. And it also decreases the activity of triglyceride synthesizing enzymes, decreases VLDL production, and inhibits synthesis of ApoB lipoprotein. So adverse effect of fish oil is it causes nausea and fish-like taste. Fish oil, fish-like taste. This is the adverse effect of fish oil and marine omega-3 fatty acids. So again, LDL, HDL is slightly increased with fish oil and marine omega-3 fatty acids. Triglycerides is slightly decreased. We already discussed this. Basically, cholesterol synthesis inhibit HMG-CoA reductase, which doesn't allow HMG-CoA to convert to mevalonate, and mevalonate is the product that finally converts to cholesterol. We do not want cholesterol, so we inhibit formation of mevalonate by inhibiting HMG-CoA reductase. Cholesterol synthesis inhibitors are cholesterol synthesis inhibitors are statins like atorvastatin, lovastatin, pravastatin, rosuvastatin, simvastatin. They inhibit HMG-CoA reductase. Niacin inhibits cholesterol to VLDL synthesis. Niacin inhibits cholesterol to VLDL synthesis. So VLDL is not formed with niacin. PCSK9 inhibitors act on LDL receptor. So PCSK9 doesn't allow LDL receptor to degrade. So LDL receptors doesn't die. They keep the LDL receptor alive, and so LDL receptor does the job of lowering cholesterol. So LDL receptor does everything. PCSK9 has just one job, that it doesn't allow LDL receptor to degrade. Okay, drugs that inhibit lipolysis, niacin inhibits lipolysis. So adipose tissue is intact. It doesn't allow lipolysis, so free fatty acids are not formed. Bile acid resorption inhibited by bile acid resins like cholestyramine, cholestyramine, and cholestyramine. These inhibit bile acid resorption, and then cholesterol absorption is inhibited by ezetimibe. Ezetimibe inhibits cholesterol absorption. Next cardiovascular drug is digoxin. Digoxin mechanism is it directly inhibits sodium potassium ATPase. This indirect inhibition of sodium calcium exchanger causes increased positive inotropy by increasing calcium intracellularly. So increasing calcium intracellularly has positive inotropy, and this stimulates vagus nerve, eventually causing lowering heart rate. So digoxin mechanism of action is very important, high yield for step 1, 2, 3. Direct inhibition of sodium potassium ATPase, direct inhibition of sodium potassium ATPase by digoxin. This causes indirect inhibition of sodium calcium exchanger. Increasing in calcium intracellularly causes positive inotropy, and this stimulates vagus nerve, causing lowering of heart rate. So you can see digoxin inhibits sodium potassium ATPase. So because digoxin inhibits this, the potassium cannot come inside, sodium cannot go outside, and so calcium remains inside the cell and eventually causing increased cardiac contraction. Next, clinical use of digoxin is it is used in heart failure to increase contractility, atrial fibrillation, decrease conduction at AV node, and depression of SA node. So if you see here, in the mechanism of action, digoxin is lowering the heart rate by stimulating vagus nerve. So digoxin has biface, like two face of a coin. So digoxin is like a coin that has two faces. It lowers heart rate. It can also increase contractility. Uh, Digoxin is used in heart failure to increase contractility. In atrial fibrillation, decreases conduction from AV node to SA node, and depression of SA node leads to uh, depression of SA node, decreased conductivity. So depression of SA node, decreased conduction at AV node. This causes lowering of contractility. Lowering of contractility helps with atrial fibrillation. Remember, we need to treat atrial fibrillation because atrial fibrillation can lead to ventricular fibrillation, and ventricular fibrillation is death. So, uh, adverse effect of digoxin is it has cholinergic effects like nausea, vomiting, diarrhea. Cholinergic effects like nausea, vomiting, diarrhea, blurry yellow color vision, blurry yellow color vision. Van Gogh was a painting, or he was a painter, so Van Glow. Arrhythmias, atrial tachycardia with AV block. It can cause arrhythmias, it can cause atrial tachycardia with AV block. Digoxin can lead to hyperkalemia, which indicates poor prognosis. Sorry. So digoxin, uh, if you see hyperkalemia on digoxin, that is poor prognosis. It means that the heart is severely failing. Factors predisposing to toxicity. What can cause digoxin toxicity? This is very important because oftentimes in hospital, patient is given digoxin without doing drug review, drug chart review, and if you see that patient is already on verapamil, amiodarone, quinidine, you need to start with very low dose of digoxin. But oftentimes, toxicity of digoxin is seen in renal failure because of renal failure causes decreased excretion. Hypokalemia, permissive for digoxin binding at potassium binding site at sodium potassium ATPase. Drug that drug that drug that displaces digoxin from tissue binding sites and decrease clearance are verapamil and amiodarone, quinidine. So factors predisposing to toxicities are renal failure, hypokalemia, and drugs that displace digoxin from tissue binding sites and decrease clearance, like verapamil, amiodarone, quinidine. Antidote for digoxin is it slowly normalizes potassium. It's a cardiac pacer. Anti-digoxin Fab fragments can be given, and magnesium Mg2 plus is given. What are antiarrhythmics? Antiarrhythmics are divided into main classes of class 1A, class 1B, class 1C, and class 3. Class 2 antiarrhythmics. Class 2 is beta blockers, and class 3 antiarrhythmics, class 4 antiarrhythmics, and other antiarrhythmics. Others are not divided into any specific classes, and they are preferably newer class of drugs. So in general, class 1A are quinidine, procainamide, disopyramide, quinidine, procainamide, disopyramide. These are class 1A drugs, and they um, mechanism of action of class 1A is moderate sodium channel blocking. It increases AP duration and increase effective refractory period, ERP, increases ERP, effective refractory period, increases QT interval, and it also blocks some potassium channels, not all, some potassium channels. So clinical use of class 1A is that it is used in both atrial and ventricular arrhythmias. So you can give quinidine, procainamide, disopyramide, and um, conditions like ectopic SVT and VT, supraventricular tachycardia, SVT, and ventricular tachycardia. So these two conditions you can give class 1A. So um, antiarrhythmics are given in the order of CAB, CAB, CAB. So class um, 1C is given first, then A, class 1A, and then class 1B. So class 1C, A, B. So these are fast. So cab is, you need a fast running cab. So C, A, B. This is the order of giving the antiarrhythmic. Class 1B is lidocaine, mixalytine. They are weak sodium channel blockers. They decrease AP duration. Given in ischemic uh, anginal conditions, and clinical use is acute ventricular arrhythmias, especially post MI. After somebody experiences myocardial infarction and they have ventricular arrhythmia, like ventricular tachycardia, ventricular fibrillation, you give them class 1B. And B, just to remember, 1B is best post MI. So, adverse effects of class 1B is CNS stimulation, depression, cardiovascular depression. Class 1C are flecainamide, propafenone. Class 1C, flecainamide, propafenone. Mechanism is it strongly blocks sodium channel. Strong sodium channel blockade, class 1C. Strong sodium channel blockade, class 1C. Strong sodium channel blockade, class 1C. And significantly prolongs ERP in AV node and accessory bypass pathway tracts. So, uh, class 1Cs significantly prolongs refractory potential in AV node and accessory bypass tracts. However, they do not have any effect on ERP in Purkinje and ventricular tissues. So, in ventricular tissue and Purkinje fibers, class 1C like flecainide, propafenone have no effect, and they have minimal effect on AP duration. Clinical uses where class 1C will be used are mostly SVT, supraventricular tachycardia, including atrial fibrillation, only as a last resort to refractory ventricular tachycardia. Refractory ventricular tachycardia, nothing, no medication is fixing ventricular tachycardia. You give them class 1C, like flecainide, propafenone. Again, 1C is contraindicated in structural and ischemic heart disease. Structural and ischemic heart disease. Structural heart disease, like somebody who underwent bypass grafting. Ischemic heart disease. Okay, so next class 2 antiarrhythmic are beta blockers. These are metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. Mechanism of action is that decreases SA and AB nodal activity by decreasing CAMP, decreasing calcium currents, not calcium level, calcium currents. So, which means that calcium cannot go in and out easily. Suppresses abnormal pacemaker by decreasing slope of phase 4. So this is slope phase 4. Slope of phase 4 is prolonged. AB node particularly sensitive to increased PR interval, esmolol very short acting. So esmolol is very short acting. Short acting. So esmolol is given mostly in beta blocker, given in type 2 aneurysms. So beta blockers are very sensitive to AV nodes, specifically increasing PR interval. So beta blockers increase PR interval. Okay, beta blockers increase PR interval. Adverse effect of beta blockers. So this is very important. High yield stuff. Beta blockers can cause impotence means no sexual urge. Impotence. Exacerbation of COPD can exacerbate COPD. So patient who has COPD, you give them beta blockers, they will die of asthma or COPD before they die of heart issue. And cardiovascular effects, like they can cause bradycardia, AV block, heart failure. So be very cautious of prescribing beta blocker to elderly people. Elderly people genuinely have low heart rate, so it can potentiate bradycardia, AV block, and heart failure. So adverse effect of beta blockers is that it can cause bradycardia, AV block, and heart failure. So be very careful of prescribing beta blockers in an elderly population. CNS effects of beta blocker is it can cause sedation, sleep alterations. Sedation, sleep alteration. May mask signs of hypoglycemia. So diabetics should be very careful of hypoglycemic signs like autonomic signs like sweating, palpitation. So beta blockers can cause sedation and sleep alteration, and it can mask hypoglycemia, means patient is hypoglycemic, but patient doesn't know that they are hypoglycemic. So it just masks, it doesn't cause hypoglycemia, it just masks hypoglycemia. Another side effect of metoprolol, it can cause dyslipidemia, which means that LDL increases. Metoprolol can cause dyslipidemia. Propranolol can exacerbate vasospasm in vasospastic angina. Propranolol can exacerbate vasospasm in vasospastic angina. Beta blockers, except the non-selective alpha and beta antagonists like carvedilol and labetalol, all beta blockers cause unopposed alpha-1 agonism if given alone for pheochromocytoma or for cocaine toxicity. Never ever, never, never, never ever give beta blocker to cocaine intoxicated cocaine addict. Treat beta blocker overdose with glucagon, atropine, saline. So gas, right? Gas is a mnemonic for beta blocker overdose. So you give glucagon, atropine, saline. Glucagon, atropine, saline is given for beta blocker overdose. So beta blocker is not given in, so takeaways. So there are three takeaways for beta blocker adverse effects. Never give beta blocker to one COPD patient. Never give beta blocker to elderly patient with bradycardia. Never give beta blocker to patient with pheochromocytoma, and never give beta blocker to uh, patient with, no, so okay, we covered all three. So COPD, bradycardia, elderly bradycardia, and pheochromocytoma. These are the three people you need to be very careful of giving beta blockers. Okay, antiarrhythmic class 3 potassium channel blockers. Class 3 are potassium channel blockers. This is also very high yield. Antiarrhythmic Antiarrhythmics of class 3 are potassium channel blockers. They are like amiodarone, ibutilide, dofetilide, sotalol. Mostly in clinics and in hospital, you will see that they only use amiodarone and sotalol. Amiodarone is more commonly used, and sotalol is not so commonly used, but it is still used in ICUs. Amiodarone is one of the drugs that is given in CPR resuscitation algorithm chart. So patient has VFib, ventricular fibrillation, you do defibrillation. Defibrillation is started with 200 joules, 200 joules. And once patient has ROSC, which means that patient has recovered, like he has normal heart rate, but he is still arrhythmic, have high potential for arrhythmia, you give them amiodarone, starting dose 150 milligram IV. You can also go up to 300 milligram TID in ICUs. Anyway, so mechanism of amiodarone is increase AP duration, increase ERP, increase QT interval, increase AP duration, increase ERP, increase QT interval. Clinical use, amiodarone is used in atrial fibrillation, atrial flutter, ventricular tachycardia. In ventricular tachycardia or ventricular fibrillation also, you can use amiodarone, sotalol. Remember, guys, rate over rhythm always in rest of your life. Rate over rhythm. First control the rate, then control the rhythm, not the other way. Okay, then adverse effects, sotalol, torsade de pontis, excessive beta blockade. Adverse effect, sotalol causes torsade de pontis, excessive beta blockade. Ibitolite can cause torsade de pontis. Amiodarone is very notorious and famous for side effects, however, still preferred. So, amiodarone can cause long-term pulmonary fibrosis, hepatotoxicity, hypothyroidism, or hyper can cause because amiodarone is 40% iodine by weight. So, it can either cause hypothyroidism or hyperthyroidism because it acts as hapten. It can also cause corneal deposits. It can also cause corneal deposits. Amiodarone can also cause blue-gray skin deposit resulting in photodermatitis. It can also cause neurologic effects. Amiodarone can cause constipation. Remember hypothyroidism? Hypothyroidism, one of the findings is constipation. And then amiodarone can also cause cardiovascular effects like bradycardia, heart block, heart failure. Bradycardia, heart block, heart failure. Bradycardia, heart block, heart failure. Again, guys, amiodarone is very important drug. Make sure amiodarone is down cold before going in the exam. Okay, next antiarrhythmic class of drug is class 4 antiarrhythmics. These are calcium channel blockers like diltiazem, verapamil. We read about it before, but because it is antiarrhythmic, we'll do it again. Antiarrhythmics, calcium channel blockers, class 4. Mechanism, it decreases conduction velocity, increases ERP, increases PR interval, increases PR interval, increases ERP, and clinical use of diltiazem and verapamil is that it helps in rate control in atrial fibrillation, flutter, and it prevents nodal arrhythmias. Adverse effect of antiarrhythmics are it causes constipation, gingival hyperplasia, flushing, edema. Cardiovascular effects are heart failure, AV block, sinus node, depression. Adverse effect of diltiazem verapamil are constipation, gingival hyperplasia, flushing, edema. Cardiovascular side effects of verapamil and diltiazem can cause failure, AV block, sinus node, depression. Okay, another antiarrhythmic is adenosine, and then lastly magnesium. Magnesium has not so clear defining role in antiarrhythmics, but here in first aid it is still included. So let's see what is adenosine. Adenosine is a very fast acting drug. Mechanism of action of adenosine is it increases potassium out of it pushes out potassium out of the cells. So adenosine increases potassium out of cells, which leads to hyperpolarizing the cell and decreases intracellular calcium. It decreases AV node conduction, decreasing AV node conduction. It's a drug of choice in diagnosing and terminating certain forms of SVT. So again, half-life of adenosine is 15 seconds, and its effect is blunted by theophylline and caffeine. Both are adenosine receptor antagonists. So theophylline and caffeine are adenosine receptor antagonist. Adenosine receptor antagonist, theophylline and caffeine. So these two things can blunt the effect of adenosine. Adverse effect of adenosine is it causes flushing, hypotension, chest pain, and a sense of impending doom or bronchospasm. So be careful of giving adenosine in COPD patients. Never, ever, never, ever give adenosine to a COPD patient. They may go into severe bronchospasm. Magnesium effects that it can help with the patient who are suffering from torsades de pointes and digoxin toxicity. So magnesium just helps um, effective in torsades de pointes and digoxin toxicity. Ivabradine is a preferably newer drug. Mechanism of action is ivabradine prolongs slow depolarization of phase 4 by selectively inhibiting sodium channels. So sodium channels, these are channels that are not classified in any specific, not intracellular, not extracellularly. So they are termed as funny sodium channel just because they were so like scientists did not put them in a specific class of drug like intracellular or extracellular sodium. So they just called it funny sodium channel. So ivabradine prolongs slow depolarization, which means it causes phase 4 depolarization by selectively inhibiting funny sodium channels. So clinical use of ivabradine is chronic HFrEF. Chronic HFrEF, heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction is a condition where you have ejection fraction lower than 55%, maybe 25%, maybe even 20 to 15%. Okay, so those conditions give them ivabradine. Adverse effect of ivabradine is that it can cause visual brightness, luminous phenomenon, which means visual brightness. It can cause hypertension, or it can also cause bradycardia. Hypertension by sodium channels. Again, funny sodium channels. We don't know what these sodium channels will do. It can cause bradycardia or it can also cause hypertension. This was adverse effect of ivabradine. This finishes cardiovascular drugs.